You good, Brian?
So, like she said, my name is Shelba. I'm working with UF Health Rehab at the Emerson campus right now. So today we're going to be talking about improving balance and preventing falls. So let's talk about falls, get some background. So according to the Center for Disease Control, also known as the CDC, more than 1 out of 4 people fall, and that's age 65 plus every year. And then less than half of those will tell their doctor about those falls. So falling once doubles your chances of falling again, and 1 out of these 5 falls can cause a serious injury. So that means either a broken bone or head injury. 800,000 patients a year are hospitalized due to falls, and most of these being head injury or a broken hip. And falls are the most common cause for a traumatic brain injury, which is surprising. In 2015, the total medical cost related to falls was over $50 billion, and 75% of these costs was accounted towards Medicare and Medicaid. In community dwelling stroke survivors, the fall rates are much higher than the general population. So in the general population, it's about 2/3 of a fall per person per year, versus a patient with a stroke may fall from about 1.5 to 5 falls per year per person. So as you can see, that's a significant difference between the general population and someone in the community with a stroke. So this diagram explains the relationship between stroke and falls, including the risk factors and then the consequences of falls. So as a result of a stroke, we know that there's a decline in physical abilities. So balance, gait, or walking ability. And then there's also some other impairments, cognitive impairments, sensory impairments that contribute to them. With that comes the risk for falling, and then also a fear of falling. And then with falls, there's a risk for fractures. And if you have already an underlying loss of bone density, known as like osteopenia or osteoporosis, then that also contributes to an increased fall risk and fracture risk as well. So with the fear of falling leads to reduced physical activity, and then that feeds into that decline in physical abilities. So as you can see, it kind of becomes a vicious cycle, which becomes hard to break once you're kind of going, you're falling, you're declining, you're not moving as much, and then it feeds right back in and then keeps happening. So that's why it's so important to intervene and kind of break this cycle as best as we can. What you need to know is that you can prevent falls, and these are some basic things that you can do to help with that. So getting an annual vision and a hearing exam is important to keep your eyeglasses and your hearing aids updated. And I'll mention that again later as to why that is important. So also, you want to be reviewing your medications, both prescription and non-prescription, with your doctor or your pharmacist regularly. And that's because lots of medications, common side effects are dizziness and lightheadedness. So you want to make sure that the cocktail of medications that you're taking is not increasing your risk for falling. Also, the effects of medications change with aging. So although you may have been on the same medication for years now, with aging, you might start feeling different side effects. And so that's important to discuss with your physician as well. And then again, also remembering to take your medications as prescribed by your doctor and not altering them, because there's a reason why certain medications are prescribed a certain way. Another simple thing that you can do to prevent falls is adequate hydration. So just drinking enough water. And that's something you want to discuss with your physician how much, because it may depend based on your medical history. And then getting up slowly from laying down to a seated or standing position. And that's because you might have experienced where you get some lightheadedness or dizziness with quick position changes due to a quick drop in that blood pressure. So if you move slowly through those positions, that usually helps to alleviate some of those symptoms. So another way you can prevent falls easily is to make your home environment safe. So simple things like removing throw rugs and using double-sided tape to keep the rugs from slipping from under. Removing things that you can easily trip over. So books, papers, shoes from stairs or places where you're commonly walking. Keeping items that you use often within reach so that you don't have to reach real high or use a step stool to do that constantly. And then consider putting a grab bar next to your toilet seat or inside the tub and shower. Using non-slip mats in the bathtub or the shower. And having handrails put in on both sides of staircases if that's a possibility. The other big thing is lighting in your home. And that includes stairs and hallways, which people sometimes often forget. So you want to consider using night lights, especially in your bedroom, your bathroom, and the hallways for when you have to use the restroom at night. Putting in brighter fluorescent bulbs, which are also cost effective, so that's another plus. And then placing a lamp near your bed so it's easy to reach for when you do have to get up at night. And then just coiling or taping any cords, wires next to the wall so that you're not tripping over them or it's not it's not a fall hazard. So footwear is also very important when it comes to falls. So what is good or safe footwear? So first of all, you always want to be wearing shoes, even in the home. Research does show that you have a decreased risk of falling if you wear shoes versus if you're going barefoot. But you want to also be wearing safe shoes. So things you want to look for, the soles of your shoes should be non-slip with good traction, and it's a thin, hard sole that you're looking for. The heel, you want it to be flat, low, and wide, about no higher than 1 inch or 1.6 centimeters, and that's just because it allows more contact with the ground and increases your stability. And then an angled heel, slightly angled, and I'll show you a picture, helps to prevent slipping as well. Of course, you want a snug fit, so any shoelaces or Velcro is a good option to allow you to adjust the shoe to your feet, because as we all know, sometimes we even have a difference between our right and our left foot, so that's great for the adjustability. And then a supportive heel collar, so that kind of firmly grips your heel and keeps it secure in that shoe. So this picture does a good job illustrating some of those features of a good shoe. So the low heel that we talked about, and then that's that angled heel that I was talking about that shows that it reduces the risk for slipping. The fastening mechanism, the thin firm sole, which is non-slip, as you can see with that traction on the bottom of that sole, and then the supportive heel collar, so it kind of just has some reinforced support on the heel, which kind of holds your heel in place and doesn't let it slip out of the shoe easily. So I have some pictures of shoes, and we'll just go through them and tell me what you guys think, if it's a good shoe or a bad shoe, and you can just shout it out.
Good.
Yep, exactly. So this is a great shoe because it has shoelaces, so it's adjustable. It has a good, firm, hard sole, and it looks like it has good traction from what you could see on the side there with the indentations. It has a good supportive heel collar to keep your foot in there. And then you can see it has a little bit of an angled heel as well, and it's low and firm. So that's all great aspects. What about this one? Yeah, so you might think like, I don't know, maybe it's a bad shoe, but it's actually a pretty good shoe because, again, the Velcro, adjustable, the rubber sole, which is thin and firm and has good grip, and then again, it has that angled heel also, which helps with that slipping. So this might be a good option for someone who doesn't like sneakers. This would be a good shoe. How about this one?
Good.
Good.
Yeah, so the one not so good thing about this shoe might be that there's no adjustability, so there's no laces or Velcro, but otherwise, all the other features are still there of that good shoe. So that's still a good shoe for someone who doesn't want to deal with, tying shoelaces or putting the Velcro on. How about these?
Bad. Bad. Oh, no.
So, I mean, these are actually considered good shoes because, again, there's lots of different types of sandals, and for people who don't like wearing sneakers, especially in the heat, or your feet are fairly sensitive, or you have other feet issues, these are actually good shoes because, again,
I see the Velcro.
Yep, exactly. So there's Velcro on both, so they're adjustable. The most important thing is that there is a backing to the shoe. So slippers, no good. But this, there is a backing, and you can see it's pretty thick and firm that it would hold your heel in place and not allow it to slide up and down.
What about exposing the toes?
So if we're talking about safety of your feet, yes, that might be a concern in this shoe. Because if you drop something or if you trip over something.
Stub the toe or something.
Right, exactly. So if we're talking about that, then these aren't the greatest, but
I think that's why we were saying that, because as seniors, that's what they tell us, don't wear something like that.
right, so
As a senior, maybe it's only for seniors.
well, no, ultimately, yes, you're right, you're correct, that closed-toe shoe would be more secure and more safer, but for people who absolutely cannot tolerate closed-toed shoes, because sometimes people have bunions, other medical issues, sensitive feet where they have like neuropathy and they're really, really sensitive, then this might be a potential option for them.
Oh, it's just a hot summer, huh?
Right, exactly, so Florida summers too. Alright, so then let's talk about what makes a shoe bad. So we already said we want to avoid going bare feet, and that's what the research shows as well. Slippers and flip-flops, because they do not secure your foot in the shoe, so it's really a tripping hazard. High or narrow heels, it decreases the contact with the ground, makes you unstable. Loose-fitting shoes, because again, that heel slipping up and down in the shoe, not really helping you. And then heavy shoes, especially with weakness, it makes it harder for you to lift and clear that foot when you're walking. Those shoes were bad, obviously. Alright. So the other aspect of preventing falls has to do with exercise. So research shows that exercise helps to prevent falls. So that's where the role of rehab comes into this. So exercise programs that are based on the knowledge of stroke-specific impairments of balance and gait are the most successful in preventing falls. So that's based on research that looked at like a general exercise program that was very generalized, not really stroke-specific, and then stroke-specific exercise programs, and that had shown to be more successful in preventing falls. And then the research also suggests that task-specific exercises are the most beneficial for persons with stroke because it drives neuroplasticity. So that illustration there on the side there is a good illustration to say what neuroplasticity is.
What type of exercise you said is the best?
So exercise that is that addresses the deficits specific to a stroke. So, a general exercise program might not be the best at preventing falls because when you're thinking about stroke rehab, you want it to be task specific, so very functional based. And you want it to have lots of intensity and repetition because that's what drives that neuroplasticity. And what that is basically exercise for your brain. So we commonly exercise different parts of our bodies. We exercise for our heart, running on the treadmill, elliptical, things like that. We do leg workouts, core workouts. So when we're thinking stroke rehab, we're thinking exercise for your brain. And that's to kind of reconnect or refire the circuits between between your brain and then the rest of your body so that they can get stronger and you can perform what you're trying to perform. Does that make sense? Basically, a comprehensive program for balance and mobility is the best way to assist with this. So, fall prevention, like we mentioned, in persons with stroke requires special considerations. So, impairments in balance, gait, motor control, perception, and vision, as well as the fear of falling, all increase the risk for falling. So, what we want to do is use an interdisciplinary, team-based approach to try to assess and treat in preventing falls. So, with our UF Health comprehensive program for balance and mobility, we have clinicians in rehab, neurology, ENT, pharmacy, that all work together to assess and treat individuals at risk for falling. So this is our team here. So you can see that rehab is a part of it, specifically PT, we do the balance assessment. Neurology, Dr. Schneider and her team, and they often communicate with pharmacy, and that goes back to how we talked about the medications, increasing your risk for falling based on common side effects. So it's very important to kind of closely monitor those. And then in ENT, ear, nose, and throat, we have Dr. Knox and his team. ENT often works with audiology for the hearing test and exams. So all of this whole team approach is what we utilize to assess and monitor falls with patients who come through our balance program. So, talking about balance, what is balance and how do we maintain it? So, balance control requires two things. Postural control, so your ability to maintain your weight over your feet, and then gaze stability. So that's the ability for you to try to use your vision to keep your eyes focused on an object while your head or your body is moving. So you need both of those to maintain your balance. So we're gonna take a look at postural control. So what does that mean? So it's two systems. There's a sensory part and a motor part. So when you have three senses that contribute to this. So your somatosensory, which is basically when you're standing and the feeling underneath your feet, you can tell whether you're on something firm or soft or uneven. Your vision, of course, and then your vestibular system, which is housed in that inner ear and is also commonly known as your equilibrium. So all three systems work together with your environment to input information to your brain regarding your balance. So if I was thrown off balance, all three of my systems would send that information up to my brain, and then my brain would create a motor output or a motor program to try to attempt to correct that loss of balance. So how does your brain do that? So it's gonna it's gonna create a motor program using different strategies. So there's three common strategies that we use to maintain our balance. Your ankle strategy, your hip strategy, and then your trunk or a stepping strategy. So all three of those, and then that results in a correction of your balance or not if it's not effective. So that is postural control. So the NeuroCom. This is a piece of equipment and technology that we use for our balance assessments that the research has shown assesses postural control well. So it's shown effective to identify fall risk for individuals with a stroke, and it compares all the testing to normal ranges for your age and your gender and your height. The research also showed that the reaction to movement was slower and the response strength was weaker on the hemiparetic side of patients with hemiparesis, and that dynamic postural control was impaired in patients with hemiparesis as compared to healthy subjects. So although we already know that exists in stroke, we wanted to see, does this piece of equipment pick those up when we use that to assess for balance. So yes, it does, and it is effective. So the other part of balance that I mentioned besides postural control is gaze stability. So again, that's the ability for you to keep your eyes fixed on an object while your head or body are in motion. So there's two things that we commonly use to assess or treat gaze stability. So it's the Envision test, and that looks at the dynamic visual acuity. So that is how well can you fixate or keep your eyes focused on an object at various distances away from you. And then the gaze stabilization test looks at what head motion speed can you keep your eyes fixed on an object. Is it only at slower speeds? Can you do it at faster speeds? Because in order to be outside in the community, we actually need to be able to keep your eyes fixed on a stable object without feeling dizzy or you're losing your balance in order to function, because there's a lot of things going on in the environment. So, and then the other thing we commonly use is the video Frenzel goggles, and I have pictures of these to show you guys. So these basically are used to observe or record eye movement during visual tracking, vestibular therapy, or during positional vertigo testing. So with any of these, a positive test would indicate if either a vestibular hypofunction, VOR or vestibulo-ocular reflex dysfunction, or positional vertigo. And these do all increase your risk for falling. But the good news is that they're all trainable. That means with rehab, vestibular rehab and neuro rehab, we can train these and alter them. So they're all modifiable and they can be improved. So these are the pictures. So this one here on your left is the Envision system. So it's basically a headpiece that goes on your head that measures precisely the speed of your head motion when you're moving and how far you're moving into either direction. And there's a monitor placed in front of you that gives you a target in different sizes, it appears, and then it's looking at how well you can keep your eyes focused on that object, and there's a verbal piece that goes along with it with the clinician. And then on your right-hand side is those video Frenzel goggles that I mentioned. So they're goggles that you put on. It lets us see your eye movement more clearly, larger, and we can also record it and then replay it to kind of figure out, sometimes there's very small minor movements that we can't really see visually to the eye. So it helps us to kind of put it up on a video screen, make it a bit larger, and be able to pick up on those. And both of these equipments we have at UHF Health Rehab as well. So another assistive technology that we often use with stroke rehab is the Bioness Vector Gait and Safety System. So what this is provides dynamic body weight support that completely and continuously support you to make sure that you won't fall. So you can feel confident, empowered to try harder tasks in therapy, work harder, and kind of alleviate some of that fear of falling. So you can tell on that diagram that the system is pretty versatile, so it can be used for sit-to-stand exercises, gait training, balance training, any type of changes in elevation, so stairs, curbs, ramps, any transfers working on getting up from the floor to a standing position, any activities of daily living, and then as well as negotiating obstacles and turns and things like that. So, looking at a little bit of research supporting the use of this. So there's lots of research that's actually done on dynamic body weight support, but I kind of highlighted a few of them here relating to stroke specifically. So there was a comparison study that looked at adults after their first stroke and that received the treadmill training with partial body weight support. And then the other group received just traditional PT with normal gait training. So the results were that the treadmill training group with the partial body weight support group showed more improvement in a symmetric and efficient gait pattern after stroke versus the group that received just traditional gait training. And then there was another study that was a randomized controlled trial, which basically is a high-level evidence study that looked at adults with stroke receiving body weight support treadmill training versus a control group that received just treadmill training, no body weight support. So there was a significant improvement in dynamic balance and gait, including the walking speed, which is important for fall risk, in a body weight support treadmill training group. So the one that got the body weight support did better with that. So from these studies and the research, we can hypothesize that the vector helps to accelerate recovery rates, improve patient outcomes, improve walking speed and dynamic balance, and then overall improve balance, mobility, and the fear of falling, especially when it's combined with conventional gait training. So this is not something we'd be using in isolation. This would be maybe a good starting point to help the patient progress and decrease that fear of falling. And then as you're progressing, we would do some overground walking treatment or balance treatment to help you kind of return back to the community, or at least make you more safe in returning back to the community. So this is a picture of that Bioness Vector Gait and Safety System, which we have at our UF Health Rehab Emerson campus. So you can tell that up there, it's a harness that comes down from the ceiling. It's hooked up to a track, and that's what really provides that body weight support. It can lift up to 200 pounds of body weight off of you, but we typically don't use that much support. We only need a little bit of support, and especially in patients with stroke. So and then that comes down and attaches to a harness that you put on. There's a trunk portion of that harness, and then there's also the leg straps right here that are optional depending on how much assistance you need. And then you can tell that, you know, they're using it over here for some stair training. So it's a great piece of equipment to use for various activities that we might work on in therapy. Another modality or equipment that we use for stroke rehab is the FES, which stands for Functional Electrical Stimulation, arm or leg cycling. So that's what that unit or bicycle looks like on the right-hand side, and that can be used for the arms and or legs. And the benefits for patients with stroke, this is what the research has shown, is decreased spasticity or muscle tone, improved strength or function, improved aerobic capacity and cardiopulmonary function, improved postural control and motor coordination. And then when it's combined with the robotic assisted locomotor training, which is what we just talked about, that vector system, you combine it with this, it increases walking speed, step length, symmetry of your walking, and balance. So, as I mentioned earlier, these are not things that we use in isolation. It's best when it's used together and based on what's appropriate for each person and what their needs are. But this is, this is a picture showing of someone using the FES cycle. And then, so that's the cycle. There's attachments here to kind of secure your legs in. And these are electrical stimulation pads that go on different muscle groups, arms or legs, depending on what muscles we want to really work on.
What is it used for stimulation? Little electrical currents?
Yeah, so it's electrical stimulation, yes. So if you've ever had TENS or muscle stim for like pain, it's very similar to that. It's a little bit higher current though to try to get the muscle to contract, but it's to help with contracting muscles that don't have good control, so, or are weak. So this is great for patients starting out with an acute acute stroke right after stroke, because if you're unable or unsafe in standing or and walking, then this is something that can be done in seated, in a wheelchair or a regular chair. And it's a great way to still work on all those things that I mentioned that still provide benefits for the patients, in a very simple manner. And we have this FES cycle at our Pavilion and our Emerson campuses. So that takes us to outpatient rehab. So as we mentioned, we know that outpatient rehab is for patients who are able to travel to a clinic and can attend individual therapy sessions and then return home to perform their home exercise programs. And then the goal being that we transition so that you're independent with the home program. So these services must be medically necessary, and an order needs to be written from the physician. And then the rehab therapists that are working with you will monitor your progress using rehab assessments and functional outcomes, and then track that over time. So the focus of outpatient rehab is to maximize your potential for recovery, safety, mobility, self-care, functional independence, and if we're talking speech, this language and communication skills. So as of 2019, which it has recently changed, Medicare law no longer limits how much it pays for your medically necessary outpatient therapy services in one calendar year. So there used to be a cap on therapy before, but as of this year, it's no longer in effect. So as long as they're,
I'm sorry to interrupt, just with that, do other insurances usually follow those same Medicare regulations?
yeah, so yes, that is correct. So most other insurances do tend to follow Medicare regulations most of the time. So that is probably, unless you have a specific, deductible or max, then you still have to meet those before it will start picking up for therapy as well. But otherwise, generally speaking, yes, most other insurances do follow Medicare guidelines. So you would be responsible for 20% of the Medicare approved amount, and then the Part B deductible applies. But if you have a secondary insurance, then that will apply towards your 20% that is not covered by Medicare Part B. So the outpatient rehab services at UF Jacksonville, so we have physical therapy, occupational therapy, speech therapy, and we also have a wheelchair clinic that's at our Pavilion location across the street. And as I mentioned, the Pavilion campus, our Emerson campus, and the UF Health North campus. So we're pretty much scattered throughout Jacksonville. So how do you initiate the process? Yeah.
What is the word juggling about?
I'm sorry, one more time.
What is the word juggling about?
The wheelchair clinic, what does that do?
Well, okay, so the wheelchair clinic is for patients who need a wheelchair, whether you need it for the community because you are not able to walk long distances. So, which I'll kind of mention right here too, is how you can get into the wheelchair clinic if you need to. But we have an occupational therapist who has lots of experience doing wheelchairs, who will do an evaluation with you and a vendor for a wheelchair, taking a look at different things and figuring out what is the best wheelchair for you to use.
So this is going to be going
So are you required to be ambulatory in order to participate in the wheelchair clinic?
No, no.
Okay.
You don't have to be ambulatory. If the doctor thinks it's medically necessary for you to have a wheelchair and will write an order for it, then we can evaluate. And then it can go through insurance, and then, depending on insurance, it can be denied or approved,
Right.
but the process can happen.
The thing is, he's already required to have a wheelchair, so does that automatically qualify him to participate or not?
So, how long has it been since he got his wheelchair? Or he doesn't have one?
2011.
2011, so it's been more 5 years. So typically, 5 years, Medicare will not cover a new piece of durable medical equipment or a wheelchair, unless there's a significant medical change. So you probably, is your current wheelchair in good condition, or is it?
Yeah, we just recently actually got another one last year.
Oh, okay, okay. So, if you have any issues within that 5-year period, your best option is to contact the vendor who gave you the wheelchair. So if you need to make modifications, you have any repair issues, you contact the vendor that gave you the wheelchair within that 5-year period.
Okay, now I'm thinking you're talking about, therapy, while you're in the wheelchair, that's what I'm talking about.
Oh, okay, no, so that wheelchair clinic, sorry, I'll clarify.
That's okay.
That wheelchair clinic is only to get a wheelchair.
Yeah, okay, that's.
Yeah.
Okay.
It's to get fitted for an appropriate wheelchair,
Okay.
yeah.
So there's no therapy for people, sorry to interrupt
In the
you,
wheelchair.
that are already in the wheelchair, there's no therapy
So,
for that.
not
Not for
specifically, but you can be in a wheelchair and come to physical therapy.
Right, I get
Yeah.
that part, but I mean, the wheelchair
The wheel
clinic
clinic.
is specifically to get someone
A new-
prepared to get in the chair and utilize it.
Right, or if you
Literally
need
do
a
that.
new chair,
Okay.
say things have changed,
Okay.
you don't fit your chair anymore, it's more than 5 years old, then you can go to the
Okay,
wheelchair.
cause
clinic.
I'm really through that when she first
Yeah,
got her, so I
sure.
knew that part.
Right,
Yeah.
right.
Likewise, that answers my question and gives me understanding there.
Yeah, he said that
Yeah, that's
answers his
clear.
question and gives him understanding now. And I thought it was about the therapy.
Yeah, I thought it
And
was.
I suggest that you guys consider doing that because there are people in wheelchair who still want to do physical activity like that.
So, I mean, if you need therapy, like any type of therapy, physical therapy, occupational therapy, even if you are primarily in a wheelchair, you can still come to any of our outpatient locations. You would just need an order from the doctor. Right, so, and that's the slide right here, so in Florida currently, for rehab services for you to see rehab services, we need an order from your physician, and it could be any physician that you see, it doesn't necessarily have to be your neurologist. And you just wanna make sure that they put the discipline on there, so PT, OT, speech, or for the wheelchair evaluation to get a new wheelchair.
That's good information.
Yep, and then the location, they can specify if you're going within the health system. So Pavilion, which is across the street, our North Campus, or Emerson, which is a little bit further south from here. Or of course, an external location, if you choose that, then they would just fax out that referral.
Where's the north location?
On Max Leggett Parkway,
Oh, Max Leggett, out
Yeah.
there,
Yeah.
right close to us.
yeah. And then and then the other thing that's necessary on the order is a therapy-related diagnosis, and that usually the doctor can take care of. But something good to know is some insurances do require your primary care to write a script. So if
Okay.
your insurance requires your primary care to kind of give you referrals to any specialist, then that's usually the case for rehab as well.
Thank you.
So, in conclusion, you have the power to prevent falls by all the things that we mentioned today.